Dr. Srinivasan, I think, won't be able to join. I believe he has some guests at home. Thank God Snehal called me and told me yesterday. Otherwise, I would not have been ready for the session today. Anyway, I'm ready now.
Okay, sir. Sir, the 2 minutes I'll just make you the host, co-host.
Yeah.
Vikram, can you make the sir co-host?
And also, I'll share my screen for a trial.
Yeah, just a minute, sir. Vikram? Just check it out, sir, right now. Yeah, I just make you co-host, sir. Just check it out once.
Yeah. You let me know. I just tried to share the screen. Is my screen visible? Satish?
Yes, sir. Yes, sir. Just make it full screen.
Yeah. Okay.
Yeah. Thank you. Very nice.
Okay.
Looking completely good
Okay.
background and.
Okay. I'll stop sharing. No problem.
I'll just message the group, sir. 2 minutes.
Yeah.
Hello, sir. Good evening.
sir.
Srinivasan has joined.
Oh, good evening, sir. Good morning, rather.
Good evening. Good evening, all of you.
Hello. Good evening.
Good evening, Dr. Snehal, Satish, Girish, Bala, sir.
Good evening, sir.
Good evening, sir. I'm
Good
just
evening, good
messaging
evening.
the others to join.
Yeah, it's
Good
all right.
evening.
No problem. Yeah.
Fine. Okay, sir.
Good evening.
Nehal, Nivedita, good evening. Nivedita is still in USA?
Yes, sir. I am in USA, sir.
Okay, okay.
Good evening, sir.
Good
Good
evening.
evening.
Good evening. Nivedita.
Hello, ma'am. Good evening.
Good evening, sir.
Hi, good evening.
Hello.
When are you returning?
I'm coming back in August 24th, sir.
Okay, okay.
Dr. Anjali. Good evening, ma'am.
Yeah, good evening.
Hello, Dr. Anjali. Nice seeing you.
Good evening,
Yeah.
sir.
Good evening. Good
Yeah.
evening, Dr. Anjali.
Good evening, sir.
Good evening, everyone.
Good evening, Bharti, ma'am. She is a senior pediatrician from Thane.
And Dr. Bharti, madam.
Good evening, madam. Good evening,
So,
madam.
yeah, nice. Kulkarni is in UK, I think. Dr. Kulkarni is in UK, I think. So usually he'll be there and giving his wonderful contributions.
Satish, can we start?
Yes, sir. It's 9 o'clock, 9:01. Yes, sir. You can. So, students, please, you can in the chat box, you can raise your queries and questions. Sir is going to take the lecture about the counseling. So, you can have any queries, any discussion, just raise the in the chat box. Thank you. Sir, please.
Dr. Bala, you have some scenarios?
I have two. You
Yeah.
can also, in
No,
fact,
no. I told you, no, I'm waiting for some PGs are coming.
Snehal
So
has,
anytime.
Snehal has agreed to, Snehal has
Yeah, yeah.
agreed to present.
Yeah,
Okay,
yeah,
let
because
me
she
share
is
my
having
screen.
a lot of genetic counseling, so it'll be nice.
Okay. Okay. Good evening, student friends. Today we are supposed to discuss counseling scenarios related to pediatrics. When Dr. Snehal reminded me that I should present something yesterday, I thought I will change the topic to communication skills within brackets counseling rather than simple counseling. Okay. The focus in the next maybe 45 minutes or maybe another 5-10 minutes more would be some definitions related to communication skills. And since most of the audience consists of postgraduates in pediatrics, some practical tips on communication skills related to pediatrics, essential components of counseling, and of course, most important thing for all of us to know is about the key communication skills. There'll be a review of the ideal technique and some suggestions for good communication or an ideal communication method. And I'll also touch upon common pitfalls in communication, particularly young pediatricians, what they make as mistakes in counseling because of lack of expertise in communication skills. Now, you must be wondering, what is the meaning of communication? Communication is a process by which a human being exchanges or shares information. That process is called communication. And you must remember, counseling is different in terms of meaning from communication. Counseling is a form of communication, but what we mean by counseling in pediatrics or medicine is that we refer to the process of giving professional help and, of course, recommendation to our client or to somebody. And what is the purpose of this counseling? Counseling actually is not a term which can be explained just by saying it's a form of communication skill. No. It actually truly aims at the process of empowering a person. That is, the person is the client or the parent or grandparent or uncle or aunt or even a friend sometimes, or the child himself or herself. The process aims at empowering that person. Why should you do this counseling? You want the other person to understand the nuances of the subject matter, and you also want the person to be enabled to take an appropriate action most suited to the situation. For example, child has a diarrhea. Mother is being advised to give ORS. So you must do the counseling in such a way the mother becomes a person empowered to understand all about ORS and also knows and learns the technique of giving ORS, when to give, when not to give, everything should be understood. That is counseling. In practice, in pediatric practice, we use the term counseling when we give professional help and recommendation to someone. Okay. And for the process of effective counseling, to ensure that a pediatrician, a student or a consultant or a registrar knows how to give counseling, he or she has to understand that counseling requires good communication skills. When you say communication skills, there are three components in the communication skills. The first component is the component of listening. Anybody who's good at communication skills, first of all, must learn the art of listening. If you're not a good listener, you can never become a good communicator. Second component is confidence building. That you must be able to communicate in such a way that the person who's listening to you has the confidence in accepting what you're saying. That's a very important process. Third, it's not a simple monotonous lecture. like what I am doing now. Yeah, I don't know if the audience is understanding or not. There's no way I can check through this web unless I put some questions and then Google Forms, etc. Put some Google Forms. I cannot make sure that the audience is understanding whatever I'm saying. But in real life, when you talk to the caregivers, periodically you must ensure that the person who's listening to you is understanding what you're saying. That is the process of checking the understanding. Then we will talk about listening. I said that anybody who has good communication skills first should develop the skills of being a good listener. When you say you should listen properly to your client, you mean that you should listen actively. It's not passive. And you must understand the situation of the patient. And you must use helpful non-verbal communication. But listening also should be an active process where you should indicate to the person who's listening to you that you are paying all the attention. You must have good eye-to-eye contact, and you must periodically appreciate or nod your head and indicate to the person who is listening to you that you are listening to him. That is non-verbal communication. The second is you should ask open questions. This is very, very important. Most of the time, in busy pediatric clinics, pediatricians want to see as many patients as possible. And they will say that the crowd has to be disposed of. And the best way to dispose of the crowd is by asking only closed questions and not ask open questions at all. I'll give you examples later. The difference between open and closed question. Just to give you an example, a mother brings a child with, say, fever. Okay. And you start putting up an open question to the mother. Like, for example, you can ask the mother, okay, ma, you say that your child has fever from yesterday. Can you give me more details about the fever, how it started, when it started, etc.? That is an open question. On the other hand, if you want to cut short the times in the session, many a time doctors will ask closed questions. Okay, ma, fever, when did it start? Oh, yesterday. Okay. And put an end to the topic. That is asking closed questions. And asking closed questions is not at all the right way of active listening. And you should use response. Achhe, acha. Oh, very good. That's very good. Something like that. Gestures. Oh, is it so? Your child was very ill last night? Oh, I'm sure it must have been very nervous for you. And gestures, you show that you are interested in listening to the person. And you have to paraphrase back what the patient says and thinks. For example, the mother says that the fever is very high and I was worried. Oh, you are worried. Very worried about seizures? What was it that was worrying you? Something like that you should ask the parents to get more information. And you should show empathy. Empathy. For example, it may be a single mother coming with a story of child having some chronic problem, right? Or there may be some economic problems in the family because of the child's chronic disease, something like that. You must show empathy. And you must make sure that the patient understands that you're showing empathy. And you should avoid words that are judgmental. Just to give you an example, no, don't do that. Don't worry about it. You can't be judgmental in making such statements. You should only be a passive listener without giving judgments on even wrong perceptions. You have to be very, very careful. And helpful non-verbal communication skills are very important. It's very, very important to have a posture. You must keep head to level, eye to eye, same level, parallel. You must maintain appropriate distance. This is very, very important. Right? These days, you have to be very, very careful. If there is a mother with a child, you have to keep appropriate. You shouldn't be too close. You shouldn't be too far. Right? Maintain an appropriate distance. And you should always have an eye contact, preferably with the mother or the father, and avoid having direct eye contact with toddlers because they may start crying. And you must remove barriers in between you and the person who's talking to you. You can't have a computer screen in between you and the parent. And you should appear as if you are there waiting to hear what the parents are saying for even 2 hours. You should show patience and interest. And you must show intimacy. Of course, you have to be, again, very, very careful, understanding the cultural sentiments of the family and the your age, and as well as the age of the person and also the sex. Intimacy, touching appropriately without offending anybody or without getting into problems. Because open question, as I said, is one that is used to gather more information than a closed question. The question usually starts with what, how, whom, why, etc. We'll take those examples in the model ASCIIs which I am putting. Closed question, you try to get specific information. Okay, was there headache or not? Yes or no? That is a closed question. And it can be answered with a single word. Okay, that's preferably avoided. You should always have open questions only. And you should show responses and gestures which will indicate to the parent that you are showing keenness and curiosity in the discussion, and you're showing interest. And you can give responses like, oh, I see, unhun, acha, okay, yes, yeah. And gestures of eye contact, nodding, smiling, facial movements, even movements of the hand and the trunk from a chair, all those gestures appropriately given will make the parents understand that you are very keen to listen to what they are saying. Paraphrasing is very, very important. It's a skill by which any health worker learns to assure the mother. The mother should understand that you are understanding what she thinks. Reflecting back or repeating what a client says, that will encourage her or him to tell more about a point of discussion. And repeating should not be done the same way they are doing it. You should repeat it in a different way so that the audience interest or the persons who are listening are still interested in listening to you. The empathy is very, very important. Sympathy should be avoided. What's the difference between empathy and sympathy? I'll just give you an example. Suppose the mother says, sir, doctor, my child fell down from the staircase and hit his head. Okay. And he started bleeding and became unconscious, something like that. Oh, is it so? Oh God, that's very sad. That is showing sympathy. That's not the way. That's not correct. You're supposed to show empathy in that. Oh, is it so? Oh, that must have been terrible for you and for your family. That is empathy. You should not show sympathy. You should show only empathy. And both for good and sad feelings, you can show empathy. For example, the mother says, child is 5 years old, and she's very happy to tell you she is swimming already very, very well. you must say, oh, excellent, good, that's very good. Okay. Similarly, the mother says that it has fallen from a staircase and got a head injury. You should express some sad feeling so that they feel that you are showing empathy to the family and the sad plight of affairs. Judgmental words should be avoided. And words like well, enough, normal in English, theek hai in Hindi, acha, or some of the judging words very often used. And you should be very, very careful in using such words, because such words, if you use them repeatedly, the caretaker may not continue. So you have to use different words to ensure that the person who is listening to you and who is talking to you is all the time interested in talking to you. What are the most important key communication skills? You must allow the parents to express in their own words. Jargon by the parents also should be discouraged. For example, child has an upper respiratory viral infection, or child has only throat pain due to a non-infectious cause. The mother might come and tell you, sir, my child is having throat infection. So avoid encouraging jargon from the parents. Avoid using jargon when you're talking to the parents. And you should observe the non-verbal clues. Sometimes non-verbal clues may give you clues to the diagnosis, like, for example, Munchausen syndrome by proxy or somatoform disorder in children. And encourage the patient to continue speaking. Don't stop. Eye-to-eye contact is very, very important. Active listening is important. These are all the important communication skills. And a person who has got good communication skills will always feel good about himself or herself. You should feel good and confident about yourself. And when you're talking to parents, it's better to avoid terms like I and me. It's always we and you rather than I and me. I and me should be avoided in communicating to the parents. Instead, we should use we and you. For example, you have a child who has come to you with 15 days fever. And after examination, you're not sure what is the cause of fever. You shouldn't be saying, I don't know what is happening. You should saying, at this point of time, we may not be able to tell you what exactly is the diagnosis. Okay. I'm sure you'll understand what we are saying. I think that is a way to communicate rather than say, I know everything. This I'm telling you this is this, etc. And very importantly, you must modulate 4 things. What are the 4 things you should modulate? Your voice, your pitch, and your speed, your pace, and your pass. Your voice should be modulated. It should vary in the volume, pitch, pace, and you should give appropriate pauses when you're talking to parents. There's a technique called soften technique, which is very, very useful to follow. S for smiling, O for open body posture, okay, with your arms resting on the sides, sitting erect and bending forward a bit, open body posture. Friendly energy, you must appear as if you have 24 hours to listen to the whole story or to communicate and counsel. And touching while talking appropriately, again, as I said, so you don't get into medical legal problems. Eye contact is important, and nodding in affirmation periodically will make the parents feel better. Non-verbal communication, eye contact and facial expressions are important. Of course, at no point of time you should show any facial expression of anger or disgust. Okay. And the commonest pitfalls, young doctors, young pediatricians have the problem of getting into are highly technical language. Talking, for example, you have a child with Kawasaki, parent, you are talking to the parent, and you first sentence you speak, Ma, this is vasculitis. Okay, they won't understand anything. So jargon should be avoided, technical language should be avoided, highly technical, and you should show appropriate concern. And of course, not listening is a pitfall. Failing to verify whether understood or not. Periodically, after every 2 or 3 statements, you must ask them, have you understood? You want me to explain once more? You should ask them. And displaying apathy. For example, patient in front of you, many a time doctors use cell phone, talk to somebody, stop it. Please go ahead, ma, like that. That's not correct. That's not correct. That's an insult to the parents, and they will lose confidence in the doctor. Because the skills of verbal communication also are important. You should know what to say. For example, there is a child with acute leukemia. Okay, you have to deliver the bad news. You should build up the story and finally only say it is leukemia. You can't say first sentence itself, your child has got blood cancer. They'll change the doctor. You know, I often used to joke to practitioners, if you have a child whom you are seeing for the first time, and the clinical features are suggestive of autism spectrum disorder, if you say in the first visit itself, with the first sentence, that this child is autistic, that's all. They'll break down, they'll change the doctor. So you have to be careful. You must know what to say, and you must know how to say, and you must know whom to say. For example, there is an aunt who's brought the child. You can't be talking about bad diseases, serious diseases, prognosis without the parents being there, unless there are specific reasons for their absence. When to say, you must be very, very careful. For example, to deliver the bad news of something like leukemia, right? You can't start the first statement saying this is blood cancer. You should build up the story in such a way, saying that this child has got a blood disorder, this child's blood cells, the white cells are more, the red cells are less, hemoglobin is low, platelets are low, and then build up a story and say this is most probably blood cancer, or this is blood cancer if you have proof. And you should also know what you should not be saying. Just now I gave you an example. First visit itself, after 2 minutes of the interview, if you say autism spectrum disorder, that's bad. Okay. You should not be revealing the diagnosis right in the first sentence. You must be very sure and confident that this is autism spectrum disorder before you deliver the bad news to them. Of course, you should build confidence of the listeners. How do you build confidence? You should accept what the other person feels or thinks. For example, many a time, in our practice, we find parents blaming ice cream given by the mother-in-law for cold or wheeze. We should not criticize. We should only, okay, ma, let us talk about it later and change the subject and talk about asthma rather than criticize the mother-in-law for the ice cream. You should praise and appreciate what a person is doing right and appropriate. For example, you have a child who's 9 months old, or who's 5 months old. The mother is breastfeeding exclusively. You should appreciate first. Oh, wonderful, ma. This is August 1st week, World Breastfeeding Week. I'm very, very happy that I'm seeing a mother who's giving exclusive breastfeeds at 5 months. You are a great mother. You should appreciate. And giving some practical help. As I told you, how to make ORS, how to prepare, how to give demonstration, that's very, very important. And giving relevant positive information. For example, what to do in the event of a seizure, first aid for seizure. Using simple language without jargon, no technological terms. And you should always give suggestions rather than commands. You should not be saying, no, ma, you should never be giving chocolates to your child. That's not the way. The child is having asthma. You should suggest it's preferable to avoid chocolates when it can cause caries teeth or bad teeth. That's the way you should give suggestions rather than give commands. And in between, you should accept what the mother or the father thinks or feels. The family may have some wrong ideas, okay, misplaced notions, right? For example, for constipation, many parents will think giving water will help. Giving water for constipation will never help. It will only increase urination. You have to give fiber. So you have to accept their wrong impressions and then pass on the correct message to them. Sometimes you have to agree with their thinking or feelings, okay, and then correct the mistakes. Disagreements, right in the beginning, they will lose confidence in you. In difficult situations, a neutral statement is very, very helpful. I'll tell you an example of a difficult situation. Sometimes in my clinic, I see parents coming to me on day 4 of fever. They will tell me, sir, day 1 itself, the other doctor gave antibiotic in such and such a clinic. I'm not happy, you won't give antibiotic. That's why I have come here. You should not be agreeing with the criticism of the parents on the doctor. You just leave aside that topic. No, ma, that doctor might have on that day 1, he might have felt that this could be have one bacterial infection. Okay, let us not talk about what he did. Let us not go into the merits of what he did, because I don't know what was there on day 1. Today, your child is all right. Now, antibiotics are not indicated. Let us not talk about what happened 3 days back. I mean, giving the expression of a neutral statement in such difficult situations will actually make sure that the patient has more confidence in you. And praising a person for the right actions of the parents, it helps boost confidence. It helps continuation of the good practice. For example, breastfeeding, willingness for accepting suggestions made by the health worker. Some practical help should be offered. For example, while you are talking to the parents, for example, you have to break a sad news, you have to give break the news to the family. Mother and father are there. It'll take about 15 minutes for you to talk to them. You can offer them at least a glass of water, switch on a fan, make the mother comfortable with the baby in her laps and something like that. This little practical help will help break inhibitions, and they will feel that you are friendly. Relevant information, factual information should be relevant, crisp in nature, and not too much at a time. For example, you have, again, a child with a disease like Kawasaki, right? In just 2-3 minutes, you can't be giving the history of Kawasaki, you can't be giving the clinical features, prognosis, monitoring, etc. So, should be relevant for that occasion, and then you can always tell them, I'm going to talk to you again. Okay. Information to be provided in general, not addressing the client in particular, is important. Always give information in a positive manner that doesn't seem threatening. Simple language is very important, and anybody should understand what you are saying. Even an uneducated parent should understand what you are saying. Should not be avoid using medical terms, complex physiology. You should not be talking about while you are explaining or giving information. And you should give only suggestions. We are not High Court or Supreme Court judges. We are not tuned to give orders. Order or command takes away a client's right to choosing the option. You can only say this has to be done, this should be done, this is the ideal way, you should do it. You can't say, no, you should do it like that. You can't order, Suggestion gives a choice to the person for adopting different options best suited for the situation. You are not the judge to decide what is best for the child. You can only tell them that this is the ideal treatment which should be offered to the child. And you should always check the understanding. For example, arranging supply of medications, making the mother comfortable, asking open questions, filling up gaps when the mother is explaining a task, asking open question for demonstration, helping in performing task and praise, etc. And you should always make sure that you arrange supply of several things like ORS as an example. And you should frequently ask open questions in between about knowledge, the cognitive domain. Just to give you an example, you are counseling a mother whose child has got an asthma and you are giving a metered dose inhaler. Doctor might say, let us revise how you will give the metered dose inhaler. Ask them to show it to you so that you can correct if there is something going wrong. Or you should not be asking, like, for example, can you enumerate the steps of expression of milk correctly? It's a closed question. The answer will be yes or no. That is not the way you get information from the parents. Mother should not feel that she is being examined. Her confidence will be lost. She should not think that she is sitting for an exam, right? While she is explaining, you should praise and encourage her periodically. If she forgets something, you should encourage her to add something. And psychomotor domain is the domain where you ask the mother to demonstrate what she is doing. For example, the correct technique of breastfeeding, where the entire areola goes to the mouth of the baby, the position, etc. And you should help the mother in performing the task and praise her periodically so that she appreciates what you are saying. In fact, if I were to ask you, you see here 6 different personalities. The father of the nation on the left top, the former Prime Minister Atal Bihari Vajpayee, excellent speaker, the present Prime Minister, Bihar Chief Minister, former Chief Minister, and of course Amitabh. Last but not the least, our own Professor Amdekar. If you see all these 6, the reason for their success, of course, they are very intelligent people, they are very hardworking. The reason for their success, if I would ask you what is the reason, I am sure everybody in the audience will say it is communication skill. Look at this statement. You know, in the TVs, in multiple channels, around afternoon time between 3 and 5, any language you put the TV on, you will find one quack or other in different Indian languages using brilliant communication skills and telling you diseases like even cancer, irreversible osteoarthritis, psoriasis, everything, all chronic diseases can be cured with their medication. Most of them are quacks. They all succeed not because of the medications, not because of science, but because of communication skills. In fact, if I were to ask you, what is the most common sensory deficit amongst all young doctors? The answer would be hearing deficit. Most of the time, we refuse to take good history. We refuse to listen to the parents. And even if you listen to them, we don't talk to them properly. So it is lack of communication skills which leads to many a problem in not only pediatrics, but also in medicine. With this, I will stop and then I'll hand out to Snehal to take up one or two communication skill stations in genetics. Then I'll come back to OSCEs and communication skills. Over to Snehal.
So thank you for the excellent slides. I have just taken one.
Yeah,
Sir,
please go ahead.
you can make me a host.
I have stopped sharing.
Sir, make me host.
Sharon, Dr. Bala.
Yeah.
Did a
Sir,
great
your
job.
comments.
Yeah, you did a
You
great
have
job.
to
And
make
of
me
course,
host, sir.
yeah, you did a great job. And of course, this is, as a breastfeeding counselor, this is a daily affair for us to
Yes.
convince some others to continue breastfeeding, that they're doing well and your child is gaining weight and this thing by
Yes,
telling. You
yes.
have mentioned all the points. Yeah, appreciate this thing and use, and of course all the steps you have mentioned. The eye level, then welcoming this thing, making them comfortable, and then this thing, looking at the eye to eye level, its contact distance, appropriate touch, and of course empathizing, accepting, empathizing, and all the steps you have mentioned of both listening and learning skills and counseling skills. Thank you so much.
Yes,
Neil, you
Snehal.
are host now.
So you have to.
Yes, sir.
Yeah.
Am I okay?
So
Sir,
for the mnemonic, there is a mnemonic called as ULCPAC. Just remember those 5 words, and then also you can do a good counseling, sir. What you have taught today, everything is in that.
Yeah. Make it full screen, Snehal.
sir, just 3-4 minutes because you are going to take OSCE, but I'm just taking.
Nowadays, we do to undergraduate students also, we teach these techniques right in the beginning when they enter the clinical posting, when they are this thing, So in Mahatma Gandhi Medical College and JIPMER, we show some this thing also, videos we have made. Dr. K. Sethuraman, we had the National Teachers Training this thing, unit. So such this thing was there, we used to show them. And regularly in Mahatma Gandhi Medical College, I was there 5 years after JIPMER, and we used to make them before they enter the clinical this thing. Yeah.
So just a prototype Down syndrome to give you an example. I have not included other diseases. And we
Go
all,
ahead.
frank trisomy is up to 95% of patients. Translocation is present in up to 3 to 4% of patients, and very few are up to 1 to 2% are mosaic. So whenever Dr. Srinivasan had asked, and sir had asked, that if there is a previous baby with Down syndrome, or there is a baby who has expired with Down syndrome, or previous pregnancy has been terminated with Down syndrome, and the pediatrician and the couple usually, for the previous baby, couple is usually following with the pediatrician. So before planning pregnancy, the questions may come to pediatricians that if this child is affected, how, whether I would have the next baby also, what precautions have to be taken. So even before going to pregnancy or obstetrician, pediatrician should know that what are the tests and what is the screening available. So at least a short information they should be given, because they are already burdened with the genetic disease. Down syndrome is the simplest of form which we should be aware of. So these are 3 types of reports which you will see if the karyotype report of the baby is done, and then it depends on the recurrence risk, that if it is frank trisomy, that father and mother are not having any problems in their karyotype, then the recurrence risk is general population risk as per the age of the mother. Like above 35, we have one in, as the age increases 30, 35, 40, the age, the risk of having a Down syndrome baby increases, that we all know. Above 40 is almost more than 1 in 75. But when the couple comes to us as preconceptional counseling before the mother is pregnant, then every mother should be offered Down syndrome screening in spite of whatever age at conception, because even if as the age increases, chances of Down syndrome increase. More than half of the pregnancies with Down syndrome happen at younger age group mothers. So we have to offer Down syndrome screening, which is still not available in all the government setups, the peripheral setups. All private hospitals, almost all obstetricians have started screening, but many of the couples or parents who will be planning their deliveries or pregnancies in government setup and coming to a pediatrician, you have to tell them that please ask the doctor or please visit an obstetrician with the request that they have to offer Down syndrome screening in the pregnancy. Even if it is not available in that particular government hospital, laboratories are doing it, so the doctors can always do it. If there is translocation in parents, depending on the translocation, the chances or recurrence risk increases. Highest, that is 100% recurrence risk is if mother is 21 translocation carrier. In that case, there is always a 100% chance. So we offer ovum donation, but it is very, very rare. Otherwise, there is a chance of having a normal baby. So first you have to reassure that even this baby you had a Down syndrome, which is a spontaneous occurrence in most of the cases. There is high chance always to have a normal baby. Only thing is we have to screen the mother for Down syndrome during the pregnancy. And even if there is a translocation, still there is a chance of having a normal pregnancy. So reassure the parents that you will have the next baby normal. So these are the prenatal counseling, that prenatal options for screening. That is non-invasive screening is first, second trimester. First trimester we have ultrasound, neonatal translucency scan, maternal serum markers, that is dual markers, beta HCG, PAPA. So it may be possible that even if we are not directly screening or having these reports, parents may come to you and show that this is my first trimester screening report. So the reports have already mentioned down the final impression, but just to tell you that this is the first trimester screening, which is widely nowadays offered. If it is NT plus blood markers, detection rate is up to 80 to 85%, and it may go up to 90% if the NT scan is done in expert hands. Second trimester screening, if the patients come late or pregnancy detection, still it is happening in India that patients, they miss first trimester screening, they don't do ultrasounds in first trimester. So if they come in second trimester, nasal bone, absent nasal bone, short bones, any soft markers or triple screen, that is AFP, UA3, beta HCG. This is almost 70 to 75%, that is specificity. And we have now new test, NIPT, which is being adopted at many private hospitals. Prices are decreasing. Still, it is very high for Indian setup, but many private patients are directly opting for NIPT, that is non-invasive prenatal screening test. Cell-free DNA of the fetus, which is coming from the placenta, and maternal blood has some of the fetal DNA. So we 10 weeks onwards, usually after NT scan, which is done in 11 to 13 weeks, we collect that sample and the fetal DNA fragments are sequenced and the Down syndrome screening is done. So it is almost 99.9%. And because of this, many couples are opting for NIPT. As the price decreases, it will be widely adopted. In Western countries, especially US, they do first trimester screening NT plus NIPT. And many states, usually they do NIPT. And new recommendation of American College of Genetic Genomics is first tier testing, screening testing is NIPT. So whoever is affording, you should tell them that that is a test which is available. You can opt for that. And if it is invasive test, which is CVS, Korean villus biopsy, amniocentesis, cord blood, then you should, because what happens is even if NIPT is 99.9, it is a screening test. So if it comes high risk, patient has to go for invasive testing, collect the sample from the fetus and do a karyotype. So patients may ask that if it is, which is the test which is 100% or gold standard, that is invasive test, that is CVS amniocentesis cord blood, because whenever in any genetic case, whenever they have a first baby affected with genetic disease, the parents are always afraid of planning next pregnancy. They want something very 100%, that whether you, doctor, whether that test would be 100%, then we should know the sensitivity, specificity of each test. Usually we show diagrams nowadays for counseling. That
1 minute, Snehal.
Yes, sir.
What is the specificity sensitivity of cell-free DNA?
Sir, for Down
cell-free
syndrome, it is
DNA.
99.9. So 13, 18, 21, it is almost more than 99%. And for rare, nowadays we have NIPT which screens all the chromosomes. So we have 1 to 22 and sex chromosomes. So for 13, 18, 21 and sex chromosomes, it is highly specific and sensitive. For rare autosomal aneuploidies, that is 22q11, 1p35. So for other chromosomes other than 13 to 18, 21, it is in some it is more than 90%, 92%. In some it is 80 to 85%. But for 13, 18, 21, it is highly specific and sensitive.
Thank you, ma.
And we are using nowadays the diagrams because everybody has laptops in their and desktops in their clinics. So it becomes very easy to tell them that we should tell them that we are taking cells and chromosomes. So this is a chromosomal disease, Down syndrome. So we always examine chromosomes of the fetus. And in DNA diseases, which whenever there is mutation, we extract the DNA of the fetus, and then we study the DNA of the fetus. So they should know what report is being done. So for example, if we are doing fetal karyotype, this is the 21 trisomy, and we are doing the karyotype of the fetus like we have done in your previous baby. So it is directly examining chromosome of the fetus. This is just an image of first trimester screening, because knuckle translucency becomes very difficult to explain for a pediatrician to the couple. So you can just display the figure that this is the thickness which is measured, and this is the image. So this is the first trimester scan, which is highly sensitive and specific also in good hands. This is NIPT, that baby's DNA, which is placental DNA, comes into the mother's blood, and there are mother's fractions also, baby's fractions also. So we extract baby's fraction, separate fetal DNA, and then it is tested for chromosomal aneuploidies. This is CVS, that is Korean Wheeler sampling, that under the ultrasound guidance, we take sample from the placental end. Then there are fetal cells which are separated, because parents are always anxious that whether we are touching the baby during the invasive testing. No, in both of the testing, we don't touch the baby. So we take fetal cells from the placenta, and in amniocentesis, we take amniotic fluid and cells floating in the amniotic fluid. So when we show images, usually it reduces the time to counsel, and it gives confidence to patients to plan the pregnancy, to be positive about their next baby, and they visit the obstetrician to choose the test. So obstetrician's job also becomes easy, because the test, there are many tests, like sir said that you have to be confident when they ask you. So the confidence will come when we understand this counseling, prenatal and preconceptional processes. And we also have to choose many tests in genetics. So if they have at least first-hand knowledge from pediatricians, they would be prepared for the pregnancy expenses. In case the pregnancy comes positive for any defective genetic defect or fetus is affected, then they have to be also ready for the medical termination of the pregnancy. So for parents to have prenatal diagnosis is quite an expensive affair. So once they get a good idea from the pediatrician which test is specific, which is sensitive, which is very diagnostic, they are prepared with finances also, and then they plan the pregnancy. So obstetricians and our jobs become easy. We tell always in obstetric conferences that if possible, immediately send the patient when pregnancy is positive. So we still have 6 to 8 weeks in hand, so that they prepare mentally, they prepare financially, because it is very difficult for them to spend 30,000 for prenatal diagnosis. Again, for MTP, it is not easy for them when they have first baby affected, all the socioeconomic problems, taboos, and so we can get acquainted with this knowledge when we offer any baby affected with any genetic disease. And whatever points sir has already told you about psychological aspects of the counseling. Thank you, sir.
Thank you. Thank you. Sir, do you have any asks, sir? Dr. Srinivasan?
No. I told you, no. Yeah, I'm just waiting
Okay.
for guests to come. Yeah.
Okay. Now, what can I share the screen now? Is my screen visible?
Yes, sir.
Sorry, one minute.
Sir, I wanted to ask till you present, So you said
Yeah.
that some of the difficult diseases are Kawasaki and also you feel that pediatricians or for us we should make a note that we have counseled this patient about this, or it is just an oral counseling. Difficult diseases sometimes.
No, but better to document that the parents have been explained and get their signature. For example, you are breaking the news of some incurable disease. It's always better with a witness. You should document everything, get their signature, and document it. But otherwise, counseling done if you write in the case sheet, I think that should be considered as evidence. But I'm not too good in these legal aspects. But I guess if there is suspicion of a trouble, it is better to document that you have spoken to them and get their signature. Just like some the surgeons taking consent. In difficult diseases, better to explain everything, document it, and get their signature and document it. It's always better to document.
Yes, thank you.
Okay.
Sir.
Now, is my screen visible?
Yes, sir.
Hello? Okay.
Yes, sir.
Now,
Yes,
I'm
sir.
just going to take two simple ASCIIs only, just to drive home the important points from the exam point of view. In fact, Snehal, now with the changed pattern of the DNB ASCII, thanks to COVID, they are not keeping any observed stations at all. Previously, our sir, Professor Srinivasa did know, in the DNB exam, 30 ASCII stations are kept, and one station was for counseling. It was always there.
Yeah, it was always
But
there.
nowadays it is not. Nowadays it is not there, because it is a centralized exam, and it is done through a video. There are no observed stations at all. Previously, we used to have observed stations on counseling. One such station, one such ASCII is what I have put here.
Yeah.
Here, you have a mother whose 2-year-old child is getting discharged after hospitalization for the first episode of nephrotic syndrome. Okay. You have a mother, and you are given a paper with a pen, and the mother actually is a difficult mother in the sense she will ask a lot of questions, and you are expected to counsel the parents. And how should a student go about doing this? If you ask me, it may look very simple, but I can tell you, even in this simple station, students in their anxiety and stress of the exams fail to do the counseling correctly. Right? For example, in this case, in this ASCII, if you look at the checklist, what is the first task? Of course, previously they used to give marks for greeting, hello, saying how are you, etc. All that is now not there. But of course, you have to be friendly and follow all the principles of communication skills. You have to introduce yourself properly, who you are and what you are going to do. For example, you can say, I'm so and so, I'm Dr. Balswana, I'm a first year resident in pediatrics. I've just now seen your daughter who's getting discharged. She's a cute girl, and she's now fine. I'm going to talk to you about your daughter's problem currently. Then ask the mother about her family and occupation, etc. Then start explaining, and you should say that I have come here to explain to you about your daughter's illness. And the most important task is to make the parents understand what this disease, nephrotic syndrome, is about. This is where a good postgraduate should always pick up a paper and try to draw a picture of a kidney, ureter, etc. And then the best way to make the parents understand is by saying that this is a disease where the kidneys, which are very efficient filters, they fail to filter and they do not reabsorb protein. You can even, in a lighter vein, mention in some apartments, the Gurkha or the security who is there will allow a few persons to go without checking. Almost similar to that, the kidneys allow a few proteins to escape getting reabsorbed. And more importantly, you should counsel the parents and make them understand that this is not kidney failure, renal failure. The moment you say renal disease, everybody will start thinking of transplant, dialysis, etc. You should tell them that this is not renal failure. And you should explain why there is swelling, edema. You should say proteins have gone out. Proteins only hold water inside the bloodstream, goes out. You can put a diagram and explain the whole thing. That's the first step. Second, you are going to start steroids, oral steroids, and you should explain about steroid therapy. Why you are giving steroids? You should say steroids prevent the leak of proteins. Okay, and you have to tell them that the child may require steroids daily for 6 weeks and alternate days for 6 weeks and even longer. And you should mention steroids. The parents might themselves have heard they are drugs with side effects. You should mention the side effects of steroids, including infection, weight gain, etc. And you should explain to them, you should follow whatever schedule that we are going to advise you. More importantly, there is a window period. You start steroid, the mother would want to know when it will start acting. You should tell them it may start acting immediately, but it may take about 10 to 14 days for remission. It doesn't work in a day or two. And you should be very optimistic about the prognosis in nephrotic syndrome. You should reassure the mother that majority of children with nephrotic syndrome ultimately are disease-free and they lead a normal life. You should also caution that relapses are very common. You need not tell them the percentage, which is approximately around 60 to 70%. You should say that many get relapses in spite of good therapy. And you can offer the option of doing urine protein testing with a dipstick. You can offer to explain how the dipstick should be used and explain the warning signs at home. For example, increasing edema, anuria, respiratory distress, seizures, fever is an emergency, abdominal pain may be because of peritonitis. And you should counsel the mother on diet. For example, most children with nephrotic syndrome don't need fluid or salt restriction. They can be given a normal diet. Unless there is massive anasarca, respiratory distress, there is no need to restrict fluids or salt. But of course, hyperlipidemia is a risk factor. So you should not be giving saturated fats in excess. And you must check the vaccination status. And you should tell them while the child is on daily steroid therapy, no live vaccine should be given either to the child or to others in the house. And you should mention then that there is a need for pneumococcal vaccine and flu vaccine, etc. And very importantly, at the end of all this, you should ask the mother what she has understood and ask her to briefly say what she has understood. Then ask her to ask more questions and then explain. That is the way you should do counseling. This is a simple station, but this is where your skills are tested. For example, you have to explain the pathophysiology, you have to explain the side effects, you have to be optimistic, you have to talk about vaccines, you have to talk about long-term prognosis, etc., etc. This is one counseling OSCE which is commonly kept. OSCE number 2. Actually, this OSCE is very similar to one which was kept in the DNB exam long time back. A 1-year-old female infant is being discharged after hospitalization for first episode of UTI for 5 days. This child was admitted for UTI and treated with the parenteral antibiotics and is being discharged with oral antibiotic first episode. You are to counsel the mother's infant. So here, your task is very clear. You have to explain to the mother what are the risk factors for UTI, what she can do to prevent UTI, and why UTI in this child, what is the follow-up the mother has to do, what are the do's and don'ts in terms of preventing UTI, antibiotic regimen, investigations such as MCU, DMSA, etc., etc. And the checklist is like this. First thing, this is a 1-year-old child, is to stress to the mother that any UTI in an infant, unless proven otherwise, is pyelonephritis. That's a very important point. It's not like adult cystitis. Every infant with UTI is likely to have pyelonephritis, and every pyelonephritis can lead to scars. And you have to show the kidney anatomy by a simple diagram, urethra, and also explain about reflux with the diagram. And you should make sure that the parents understand that this child also could be having a vesico-ureteric reflux, which is one of the known risk factors for UTI. And some predisposing factors, like, for example, constipation, bowel bladder dysfunction, threadworm infestation, vaginal synechia, phimosis, and congenital anomalies of the urinary tract would predispose to UTI. You should tell the mother UTI is not treated with one single dose or 3 days course. It is always 10 to 14 days. She has to be adherent to the regimen prescribed. And the other important point which you should stress is that UTI can recur, and recurrence of UTI may not be always with urinary symptoms, particularly below the age of 3 years. There might be only fever or increased frequency, foul smelling urine, dribbling, dysuria, vomiting, etc. Explains that these symptoms may not be there in young infants. The symptoms may be vague. And explain the preventive measures like constipation, washing genitals from front to back in girls, plenty of fluids, prophylactic drugs, the threadworm infestation, and also explain the need for investigation. Explain the need for investigation, including MCU, DMSA, etc. And you should avoid jargon. For example, you shouldn't be using pyelonephritis. Okay. Even vesico-ureteric reflux, the parents might not understand. You have to explain to them with a diagram. It's actually the urine which is, the urinary tract which should adopt only one-way traffic. Some children may allow bilateral traffic. That is vesico-ureteric reflux. You should show empathy. And as I said earlier, you should have good eye-to-eye contact. You should ask more open questions to check understanding. And in the end, you should summarize and ask if the mother has understood everything. And finally, end with the reassurance that most children with UTI are likely to recover without sequelae. Prognosis should be good otherwise in most UTI. This is the way you should counsel in this case. Okay. Counseling station 3. Breath holding spell. This is a very difficult station for most students. Counsel this mother who's 1 year old who has frequent breath holding spells. This is a nightmare for many students. What is expected in the session? I am not putting any checklist. What is expected from the student is that the student must understand what is breath holding spell, what are the features of typical breath holding spells, what is the pathogenesis of breath holding spells, what should we do, what should the parents do, is there a need for investigations, is there a need for any pharmacotherapy? These are all the questions you should address. Very importantly, parents whose infants have breath holding spell, they are very scared for 2 reasons. You must understand that. One is that they may think it is like a seizure. Second, the moment the baby stops breathing and loses consciousness, they get scared about the baby dying of the spell. So basically, you have to explain the benign nature of the disease if you are confident about diagnosis. You should reassure them repeatedly. You should tell them most infants and toddlers who have breath holding spells lead a normal life. It is not epilepsy. It is not a cardiac problem. In fact, I remember a Forfer textbook of pediatrics used to mention breath holding spell as the output of a battle between a child who is striving for autonomy and parents who want to enforce discipline. Is actually a parental conflict. An adamant child only gets breath holding spell. It's more common in males, often tends to run in families, occurs anywhere between 6 months to 3 years. But there's been reported even in newborns. Right? The typical story is that the child cries for a long time, holds breath, may become pale or sinus, may stop breathing, sometimes throw a few jerks, and then starts crying again, becomes normal. Right? What you should explain to the parents is that it has got good prognosis, it doesn't kill, and you should tell them that they should not be more anxious, they should not react with incorrect methods like pouring water, banging the child, etc., giving a key, etc. All they have to do is to put the baby over the shoulder and gently stimulate. Most of the time, the baby becomes normal. And it tends to run in families. You should explain to them iron supplementation might help. If there is iron deficiency anemia, certainly iron supplementation could help. Other than that, medications don't help. Anticonvulsants are not needed. If you're sure about diagnosing EEG and the MRI and imaging, CT scan are not required, reassure. This is what you should do when you have to counsel a family where there is a history of breath holding spells in an infant. Okay, you should remove the fear of the parents. One, about the disease. Second, about the fear of death also. And you should tell them the moment child starts crying, they should move away from the scene of crying. That will actually reduce the risk of breath holding spells. They should not pamper the child. Because of the fear of crying, they should not give in to whatever the child wants. Okay? And this is another station. So I have given you 3 examples of husky stations which can be kept as stations for communication skills. Of course, your communication skills can be tested by ASCII stations where you might be asked to take a history, you might be asked to break up bad news, you must be asked to counsel regarding a drug or a disease or a diagnosis like Down syndrome, etc. Okay, any such station can be kept for your exams. I'm sure youngsters who have good communication skills will always do well, not only in exam, but also in their career. Thank you very much. That's all from me, Snehal and Satish. I would
Thanks a lot, sir. Thanks a lot.
invite
Very
Professor,
nice.
I would invite Professor Srinivasan's comments.
Yeah. Of course, it's brilliant, and of course, we have conducted this during this. We used to go to various places during a particular this thing. For training of PGs in ASCII stations. So this is one of the most important counseling which is being done. And of course, Dr. Sneha has mentioned about the genetic conditions, how it has to be approached, etc. So very good. I'm sure nowadays, of course, a lot of videos are also available in the of counseling in ASCII stations, and Dr. Tushar also has put up a lot of counseling. So I think PGs have enough material to learn from them. It's very important, and undergraduates are also being taught nowadays how to approach patients and how to make them confident about certain conditions and their level thing. So I think people now know the importance of talking to families in a very careful manner, so that a lot of litigation is there. So excellent session. Thank you.
Thank you, sir. Thank you.
Yes, Snehal and Satish.
No,
If
sir,
there are
thank
any
you so much
questions
for
in this chat
elaborate
box,
session and language you have used, sir. That is very self-explanatory also, and it was very elaborate. All the points covered here.
Yeah, thank you very much.
yes, Satish.
Yes, sir. Thank you very much. And I think we are learning than students more now to counsel the parents. And basically, when we see that like difficult cases, what they see, we are stuck there, and at little bit of your advice can become a very boon that time actually.
Yeah. Yes. He has been a very popular practitioner because of these counseling skills.
Yes.
And also very rational drug prescriber.
Okay.
Good night, all of you.
Yeah, so we teach the undergraduates also by the ATCOM module, which is very common nowadays in the medical college. That
Yeah,
attitude,
nowadays it has become a regular
yeah,
this thing to talk.
attitude, ethics, and your communication. There
Before
is a good
clinical
book
medicine
also.
starts, they are
Yeah.
given this training, and
Yeah.
lot of videos are also shown made under this thing, how they are counseling, etc.
But I still remember we had I don't know what Professor Srinivasan remembers. Once it was kept in the exam also. There was a video of a student talking to a parent, and in between using the cell phone, not looking at the parents.
Yeah.
Students,
They were supposed to
students being asked to identify the errors in counseling.
Correct.
Yeah.
Even we show them a good video, bad video first, and then a good video, and then we tell them to compare.
Correct.
Breaking the bad news, not in the corridor, take them to a private room, make comfortable, keep the baby in their lap. So many, Sir, but excellent session.
Yeah, nowadays
just want to
students
tell-
understand the importance of this counseling, because many litigations are occurring because of bad communication skill. So I think this is very important. So naturally, the training
So
must
there
be
is
given.
there is a mnemonic, sir. What I always tell, like unpack, ask, active listening, praise what she has really done. As you said, breastfeeding, she's breastfed her. Then advise, but a minimum advice, not too much knowledge to be given. But then check whether she understood, like how to prepare
very
a
important.
ORS
Yeah,
at
in
home.
simple language, in jargon.
Correct.
Yeah.
Very nice, sir, but learn many things.
and
Yeah.
never be judgmental words.
Correct. Yes.
Fine.
Thank you, sir.
Thank you, sir. Good night.
Okay.
Thank you.
Okay.
Thank you so
Thank you.
much.
Thank you. Good night.
Good night,
Thanks.
all of you.
Good night.
Have a
Good night.
nice.
Good night.
Good night,
Good
sir.
night.
Good. Thank you. Thank you.
Good night. Thank you.